Good morning, Professor Paul MARIK. You're a professor of medicine at the Eastern Virginia Medical School, and thanks a lot for giving us some of your time on the Francois channel for our viewers and readers. You're a known expert for vitamin C, and we've seen and we've heard a lot about you in the recent COVID crisis surrounding the early treatments. Maybe for the viewers in France, it would be helpful if you could say a few words about yourself, because you have had a long career as a medical expert and practitioner. And if anything you want to say about yourself by way of introduction would be very helpful.
Sure. Well, thank you kindly for inviting me today. It's a pleasure to be here. So I am a critical care physician. So I practice critical care in the intensive care unit exclusively. I've done that for the last 30 years. I was trained in South Africa, where I did most of my training. I then did a fellowship in London, Ontario, Canada, in critical care, and have spent the last 25 years in the US in a number of teaching hospitals. My interests include most ICU topics, but particularly sepsis, and obviously now COVID, because there's a very close overlap between sepsis and septic shock and COVID. So that's kind of how my interest started in this very bizarre disease.
And thanks a lot for this introduction. And just to get you started on when you got into this this pandemic, what were your thoughts when you actually first heard about this disease and so your first patient?
Yeah, so we had the advantage of having been witness to what happened in Wuhan, and then in Italy, and then in New York City. So by the time it came to us in Norfolk, Virginia, which was towards the middle of March, we already had a lot of, fairly good information at hand on how to treat this disease. So indeed, we had developed our protocol before even seeing the first patient. And there were a number of things about this disease which were obvious. And I think the medical leadership across the world failed in this regard. So we recognized this very quickly, and then actually practicing at the bedside, because I think you have to practice at the bedside to see these patients, to treat these patients, to live with these patients, to understand the disease. And it's most annoying when you have these ivory tower people who've never seen a COVID patient telling the rest of the world how to manage these people. And this is a very complicated disease. It's very complicated. And you really have to be clinically astute. You have to observe what happens at the bedside. And you have to appreciate the enormous spectrum of this disease. So I suppose the first thing we recognized, so we knew this from Italy, and then we saw this firsthand ourselves, is that once the patients reach the ICU, this is a profound inflammatory disease. And it's really important to emphasize that it's not the virus that's killing the host. We passed that. It's the viral debris and the host's very bizarre immune response, which is destroying the host. And we know that now categorically, definitively, absolutely, that autopsy series show very little cytopathic effect of the virus. It's the host's immune response. So what did they do in Italy and New York? They supported them. The treatment was supportive care. They allowed these patients to develop progressive lung injury to the point of irreversible lung injury and death. We knew right from the beginning that you needed potent anti-inflammatory agents. So, starting March the 23rd, we were advocating for the use of corticosteroids because corticosteroids are the most powerful anti-inflammatory agents. It should be noted that at that time, the WHO and every other medical organization cautioned against the use of steroids.
Why would you say they actually cautioned against it?
That's what the WHO document, in their document up until May the 27th, the WHO document for the treatment of COVID said corticosteroids are not recommended. And this was based on an erroneous interpretation of data from SARS, and obviously a lack of anyone actually understanding this disease. If you understand the pathobiology of this disease, you know you need to use steroids. So the lack of using corticosteroids for many, many months led to many deaths that could have been avoided. The second thing we noted that, and this is obvious, this is not rocket science, you just have to be a clinician at the bedside, is that COVID causes a profound prothrombotic state. It causes clotting. It causes clotting in the little blood vessels, and it causes clotting in the big blood vessels. So what we said is you need to use anticoagulants, blood thinners, to treat this disease. We were saying this right from March. However, every single medical organization said, do not anticoagulate. We now know in the last month the results of the active study, as well as 3 other randomized studies, have shown that in hospitalized patients, anticoagulation reduces the risk of death. So, you know, the editor of New England Journal said we were lucky. We were lucky to make these assumptions. It wasn't luck. It has nothing to do with luck. It has to do with common sense and clinical intuition and understanding. So, you know, there's been a complete failure of the major medical systems across this world to provide a comprehensive plan and management strategy for COVID. So, you know, that's the acute part. But, you know, what we've now focused on is preventing or limiting COVID. You know, it's kind of obvious. We know this. Prevention is worth a pound of prevention. You want to prevent this disease. And, you know, there are many things you can do to prevent patients getting COVID. And most importantly, the early treatment, when people are infected early, day one, you want to treat them. However, the WHO and the NIH have been completely silent. Currently, the NIH says there's no treatment for the early management of COVID. So what we get, patients tell us they have COVID, they call their doctors say, I'm sorry, there's no treatment. You've got to stay at home. You have to go blue and struggle to breathe. When you can no longer breathe, then you need to go to the emergency department. That is absolutely unacceptable approach to this disease, because we know there are things you can do. There are things you can do, people can do at home to mitigate this disease, prevent its progressing. Most importantly, it prevents spread to other people. And even more importantly, if you treat it early, you're much more likely to prevent the post-COVID syndrome, the long haulers. We know at least 60% of patients get the long haul syndrome. And we believe this is due to the completely dysfunctional immune system. If you treat them early, you will likely prevent this. So I think across the board, there has been a total and absolute failure of the major medical systems across the world to provide guidance to physicians and to educate the public on what they must do. The biggest tragedy we see is patients who are short of breath, staying at home until they can't really breathe any longer and then come to hospital. The problem with COVID is the longer you wait, the more damage you get to the lung and the more irreversible it becomes. So the message has to be, I need to stress this, the message has to be 1, early treatment, and 2, if you get short of breath, you need to go directly to the hospital. By waiting at home causes progressive lung injury. So that's my brief introductory summary.
Yeah, it's a lot. It's a long introduction, but I think it's quite comprehensive. You know, explaining sort of the critical care, the ICU sort of situation, and the early treatment. And of course, what you're saying appears to be common sense. So why would you say we've lost common sense?
Yes. So Xavier, you ask the $1 million question is, so, you know, I think the world has gone mad, and the question is, why are we in the situation we're in? And, you know, it's unfortunate to, you know, bring up conspiracy theories and sinister motivations. But you know what? You just have to wonder about underlying very strong economic and other factors that are there to provide misinformation, because, you know, there are a lot of expensive medications that are around and people are profiteering from people's suffering. Let me say that again. It's a truly astonishing statement that there are people who are profiteering from human misery and suffering. And I think the profit motive is largely driving this misinformation. It's truly, you know, I don't know of any other explanation. It's saddening, it's disgraceful, it's despicable. But I have no other explanation of why there's such powerful forces at play to do the right thing.
So does it mean that we've turned the World Health Organization into the World Drug Organization? So mistaken drug and health?
Yes. So, you know, there's simple things you can look at, you know, very simple, cheap, repurposed drugs. I mean, you can take vitamin D, for example. You know, it's not a political drug. You know, it's cheap. Everybody can buy it at the pharmacy. We know that if you're vitamin D deficient, it increases your risk of getting COVID. Yep. It increases your risk of dying from COVID. We know if you take vitamin D, it can prevent COVID. It can prevent you dying from COVID. We know that certain people are vulnerable to vitamin D deficiency, particularly in winter, particularly if you're north of 40 degrees latitude, if you're obese, if you're old, if you're in a long-term care facility, you're going to be vitamin D deficient. For heaven's sake, why have the health authorities not recommended that people take vitamin D? What's interesting, Dr. Fauci himself takes vitamin D. Dr. Fauci has publicly admitted he takes vitamin D. However, the NIH will not recommend the use of vitamin D. It is inexplainable to me.
And Professor, we've read a lot of papers about you and your work around one of the repurposed drug, which is called ivermectine, as a treatment, either as an early treatment or as a ICU treatment. How did you come about thinking about ivermectin? Is it through observation? Is it through experience?
Yeah, so I mean, it's a good question. I mean, most of our recommendations are based on, you know, review of the scientific literature, which is really important. You know, you have to follow the science, and then our personal observations. So, you know, the story started in about April, you know, with these two researchers out of Australia, Kelly and Wagstaff, who did an in vitro experiment. So this is in a test tube, looking at the use of ivermectin to kill SARS-CoV-2. and they showed a dramatic benefit. So, you know, starting then, it was on our radar. And in our protocol, if you look, we actually had it as an option. So the way we've done it is when there's strong data, we recommend something. When there's weakish data, we say, you know what, this is a potential option. So at that time, there wasn't any clinical data. It looked interesting, but there wasn't clinical data. However, over time, and maybe up until October, we then noticed a very strong signal showing the benefits of ivermectin. So it was really starting in October that we started to recommend, we changed from optional to strongly recommend the use of ivermectin. So just let me tell you a little bit about ivermectin. So, you know, this was discovered by Satoshi Omori in 1975. He, in fact, won the Nobel Prize for his discovery. It was made clinically available in 1985. Since 1985, 3.7 billion, that's with a B, doses of ivermectin have been distributed for the treatment of parasitic diseases. And it's had a major impact on parasitic diseases across the world. You know, the treatment of river blindness, which was a terrible disease, is basically being come under control with the use of ivermectin. What's truly remarkable about this drug, firstly, it's safe. So there's been a lot of misinformation about the safety of ivermectin. So as we said, 3.7 million people, 3.7 billion doses have been dispensed. It is exceedingly safe. So what I can tell you, and this is very interesting, and this is from the WHO. The WHO has a pharmacovigilance database. They record side effects of medications across the world in an ongoing fashion. In the last 30 years, the WHO has reported 16 deaths possibly related to ivermectin. In the last 2 months, the WHO has recorded over 1,200 deaths, 1,200 deaths related to the SARS-CoV-2 vaccine. So that just puts it in perspective. We're not anti-vaccination, but this is one of the safest medications there is on this planet. The NIH and CDC talk about liver dysfunction. We're aware of one single patient who developed possible hepatitis due to ivermectin. So there's been a campaign to discredit this drug in terms of its safety. Its safety is completely unparalleled. The next thing which is interesting is, apart from being a very effective antiparasitic drug, this drug has broad spectrum antiviral properties. So we know it's effective against Zika virus. We know it's effective against influenza virus. And we now know it's effective against SARS-CoV-2. And it acts probably by multiple mechanisms to prevent both viral attachment to the cell and viral replication. The data is unequivocal, because if you give household contacts, so these are people in a family, someone has SARS-CoV-2, you prophylax them with ivermectin versus placebo. If you look at the placebo, about 50% of household contacts get SARS-CoV-2. If you prophylax with ivermectin, it's about 5 to 6%. So we know it has antiviral properties. What's even more interesting is a study out of Israel. So many of the detractors say, well, you know, these are studies from low-income countries that you can't trust. So recently there was a study from Israel, a really good study. It was completely double-blind, randomized. So what they did is people who had COVID, what they do in Israel, they put them in a hotel. So what they then did is these people who had SARS-CoV-2, half of them got ivermectin, half of them got placebo. And they followed these patients every second day to see about how they were viral shedding. If you gave ivermectin, the people who got ivermectin had much more rapid clearance of the virus. So people who were treated with ivermectin had much more rapid clearance of the virus. So for people to say that this does not have antiviral properties is completely and utterly false. We have extensive data that ivermectin has antiviral properties. It is profoundly safe. The problem is a single 12 milligram tablet, the WHO has access to, my understanding is 2 cents, costs 2 cents. The cost of remdesivir in the US is $3,000 a course. We know remdesivir does not reduce mortality. The WHO no longer recommends the use of remdesivir. However, the NIH still recommends remdesivir for the treatment of SARS-CoV-2. So you know what? You and your listeners can make whatever judgments you want to do about that.
So it's 2 cents versus $3,000. So it's a fractional of the cost. Of course, there are some consequences on that. Professor, you've made a publication